seen something like me.
Hello and welcome to another episode of Walking with Walfinch. Today I'm very pleased to have finally got Max Parmentier, the CEO and co-founder of Birdie, on the show. Welcome, Max.
Thank you.
So, what on earth is Birdie?
Well, Birdie is a leading home healthcare platform
Yeah.
to really help care providers deliver better care in the community and at home, particularly for older adults. We provide a range of software services for providers to care better, to manage their back-end operations, to really cater the best services for the families as well. So quite a broad range of services. See us as the operating platform for care providers to deliver the best care possible.
Wonderful. And so Max, what brought you to this? Because this is a very niche space.
It is a very niche space. They're growing very fast, as you know.
And I like it. Right?
Yeah, well, I do like it as well, and I'm quite passionate. I think there's it's personal story. Of course, there's always a bit of a personal story when you talk about healthcare. With my grandfather, who had to be placed in a care home because there was no home care services available. That was in Belgium. And I think that really triggered for me a very interesting question, which is how do we look after our elders and how society is dealing with aging overall. Then we looked at the trends, that we're all aware of, but the pace at which our society is aging and this kind of phase of life where people fall sick but die later, for us was completely unappreciated. Like it's just the magnitude of the shock that we're going to experience as a society is unparalleled. And combined with the fact that it is now absolutely clear for everyone that the healthcare will shift towards the community. That the future of healthcare will be very much closer to the patient in a much more personalized, preventative, holistic fashion. There's no government on earth who doesn't say that, who doesn't support that, who doesn't push that. And so for us, it was quite natural to say, well, if we really want to fix the healthcare crisis, which is obvious right now, why don't we focus on healthcare at home, which is a future? And when we looked at the home healthcare, we looked at these thousands of care providers who, for us, are the future of healthcare. What we call them the future primary care, the future frontline staff. But today, who are still really poorly equipped in technology to really deliver the best care possible, and certainly, cannot also perform the services of tomorrow, which is much more healthcare type services, because of the lack of technology. And so, with the technology advancement, the progress of, software and so on, it was so obvious for us that one of the ways to fix healthcare was to bring the best technology for these providers and support them on that journey to become the healthcare providers of the future. And we can elaborate on that. But
yeah, I think that's really interesting because I think you and I met about, 3 years, maybe just over ago.
Something like that.
We were on a panel together.
Yeah,
at the
absolutely.
And what I found really interesting was your take on data and how one would slice and dice information that you get through home care and how that would really help support preventative measure.
Yeah.
Because I kind of look at where we are right now, and we're kind of in that it's sort of medicine 3.0.
Yes.
With bloodletting being 1.0, cure being 2.0, and prevention really being 3.0. And we're moving into that space.
Absolutely. I think there's a few elements to what you just said. I think the idea of prevention for me is key. And that takes data, but more than data. It takes, for me, a much more holistic approach to care, which is not delivered today. Today is very reactive. We rush people to the hospital, we give them medication, we hope they're going to get better. We know it doesn't work. And so number one is, how can we bring not hours of care or one intervention, but a real full-fledged approach to care that may include GP on call, medication delivery, obviously hours of care, physical care, but it could be also companionship, it could be mental health support, and sometimes it's a human, sometimes it's technology. And I think these two will go hand in hand, particularly in a world where we are severely under capacity, right? So how can we reinvent the experience of care to keep people much healthier at home, and make it much more holistic. And then on the back of that, you're right, there's a question of how can we make the data and the use of data much better for efficiency, because I think that's important.
Yeah.
There's still, what I say to my team is we should help providers automate anything that's not physical care. There's still 30% of their time spent on admin time and so on.
Is that right?
Yes. How could we really, I mean, if you look at labor costs, it's about 95% of the P&L of a provider. But I think that out of the labor cost, there's probably 20 to 30% that's admin or related, or at least that you can probably optimize if you have better visibility in your business, if you are much more proactive, if you actually have more oversight. So that's one. Data can help you be more efficient. You automate or facilitate anything that's not caring. You pay for care, not for admin tasks. And then on the prevention side, we now sit on such an incredibly rich data set. You're right. So it's like you know exactly with the highest resolution the health and well-being of a patient at all time that one of your franchisees care for. That is incredibly powerful, because with that, when we talk about doctors, when we talk about hospitals having data, they only have snapshots every month or every 3 months of a patient. In home healthcare, you have longitudinal data. You have a snapshot picture every day, or 3-4 times a day, of a patient combined with the medical history of that patient. It's incredibly powerful to really start paving the way for much more preventative care journeys, saying, well, I know exactly what's going on here. I know exactly where it can lead to. What kind of intervention do we need to put in place right now to make sure that we take the happy path and not the sad path? And technology is today available. So you have the data and you have the models in AI today to use the data. So we're grasping it. And when we met you and I think we were just at the beginning of the journey. Now it's just ready, which is very, very exciting.
And I think that is really exciting, because actually, when we were speaking back then, I thought, gosh, this is the future. This is the direction of travel. And it's really wonderful to think we're here.
Absolutely.
We're in the future.
Yes, we are. And it's moving. Not only are we in the future, but the future is moving so fast. It's like what I said, 1 week ago wasn't available then, And so, like Anthropic, we just released their healthcare model. It's performing better than the doctor. And there's lots of course, safeguarding issues that we need to look at. But in a matter of weeks, they released something that was impossible before. Imagine where we can be in a year. It's like the speed of innovation has really accelerated massively.
And I think that's really sort of interesting when you dig into that. And I think, so as a care provider myself, what should I be looking at when I'm talking about prevention? And we've got a lot of care providers that tune in. When they're looking at prevention, thinking, well, I don't want Mr. Jones to be hospitalized. How do I stop that happening? What am I looking at?
So I think first of all, there's a bit of a question of why would you do it and how would you do it? I'll be honest, we released a first pilot, and I think I mentioned that to you, a few years ago, where we combined different data sets. We didn't have AI at the time, but we were using machine learning, which is AI, but we didn't have LLMs. To, long story short, identify issues before doctor, before care. Our use case was urinary tract infection, which you know very well. And we actually had loads of cases where we said to providers, hey, Mrs. Smith, 80% chances that she has a UTI.
Right, okay.
Providers would tell us, I don't want to know this.
Okay.
I don't want to know this because I'm, paid for the hour of care. You're putting more burden on me, and I just don't have the capacity to deal with these things. And so we didn't think about that at all, which is, with responsibility, comes a reward as well. And that hasn't been thought through. So to your question, number one, I would start thinking about what kind of packages, what kind of services do you want to offer to your customers, to your clients, to your care recipients? Because in public settings, it's really hard to monetize prevention. And if you don't find a way to reward people to prevent instead of react, they will not do it. That's my own experience.
And so what is that? A different billing system, like a subscription-based model or something? Or?
You could totally think about, maybe for private pay, you could think about a monthly subscription model where you have someone continuously looking at the data and with the necessary alerts. You're going to always need a human in the loop, but that could be a geriatrician who looks at what's going on. And so that's definitely something that I believe families would be quite excited about.
Yeah.
Interestingly, we have a few private providers talking about that at the moment with us, saying, you got the data, you got the LLMs, we can really have a dashboard with a doctor being told where to look at because these models tell you that there's a risk there and so on. And families are very keen. I had that experience with my grandfather. I wished we had someone telling me, look, we're going to keep an eye on him, despite the moment where a carer is in the room, So that's one thing. The other thing is I would start, small steps. The first step is safeguarding and compliance and, CQC rating. Today, like just auditing the care notes is something that nobody does really.
Yeah.
And, yes, it's done, but with lots of people, just mindful of the crash that's going to happen here. It's being done, the sort of auditing care notes is happening, but not always and not thoroughly because it's very time consuming.
Yeah.
If you think about, compliance, these models of prevention, just like audit the notes, flag any risk, and that for compliance matters will already be huge.
And so you're saying that the LLM can go in,
absolutely
audit the notes, and give you the alerts and say, here we go.
We're looking at that closely at Birdie, and I really expect that this year we will be releasing something. Exactly.
Because actually that's, I was listening to this speaker talking about AI and how to utilize it in your business. And something that he said that really sat with me was that, look, AI is very sexy. Yes. However, if you are investing time, effort, and money in your business with AI, it's got to have an ROI. If it doesn't add EBITDA, why are you bothering to do it?
Absolutely.
And I thought, well, that's so interesting because actually everyone's racing to, I need to do X, and actually, I want to make this fancy dashboard. But, well, it's giving me all the information already, and it doesn't add anything.
I so much agree. Yes. There's two approaches to AI. One is, use the technology and find the problem. And the other one is what's the problem in the ROI and find a solution for it. And obviously we want to take the second one, but it means a lot. Like what we do is we look at care providers, how they operate, where they spend and where's the most time, or where there's the biggest safeguarding or quality risk. And that's where we start from.
Yeah.
So you want to start from the pain point, the big one. And then you look at what are the solutions, including technology, including AI that could solve it. Auditing is one. You got the data. There's someone skimming through the notes all day long. Of course, run an LLM, flag the issues. Yeah. You've just saved 5 hours of their time, and you know that you're more compliant.
You multiply that out by a year, and it really adds up. Exactly. It's very interesting. Yeah.
So, and the view we have over time is to really move towards agentic orchestration, which is the idea of saying once you have a platform, and we pride ourselves to be basically the only fully built, organically built platform for home care. Once you have a platform, the foundation's right, you have basically all these workflows that have been digitized, if you wish. At least they're not on paper anymore. They are in a system for a care coordinator, for a care manager, for a finance manager. The next step is to basically build these agents on top of it to say, where do you waste the most time? What are the mundane tasks that you, finance manager, you do for the month-end payroll or invoicing, or for you, care coordinator, on the rostering? We're not here to replace you. We're here to co-pilot you. But where do you waste the most time? And that's where we need to focus and basically solve that problem first. And building these agents, this orchestration of agents on top of the core foundations. That's how we think about our product.
I think that's really interesting when you're, yes, I use Birdie.
Thank you. This is not paid advertising.
This is not paid advertising. But I think it's one of the things that really attracts me to the system, because look, no system is perfect, right? And so I'm sort of fully aware of that. But I think one of the things that really attracts me is the thinking behind the system, because there's lots of systems that will do the work just fine, no issues. However, what I think is really intriguing is that when we're thinking about tomorrow and we're building something for tomorrow, if I think about Walfinch and what I'm trying to do there, I'm trying to build something that is relevant in 10 years' time. Not just relevant today. I think there's lots of providers that are relevant today.
But then I would love to ask you the question, if I may,
Yeah.
which is what does home care look like in 10 years, really?
I think it's a completely different thing to today. I think actually we're moving very much in that home health space. I think if we look at the fact that we've effectively got government failure within the sector, I'm quite sort of happy to say that publicly. I think that we have got local authorities that don't pay a respectable figure to care providers. We actually have got local authorities that pay under minimum wage to care providers. So that work will just stop happening. And so the private market will change.
Step in. Yeah.
Also, I think when we look at the NHS and we look at the burden on the NHS, I think a lot of that work will start happening at home. We're already seeing a move in that. I think currently we're probably looking at about 10% of the market is home healthcare.
Yeah.
I think that number will probably triple in the next 10 years, if not more. And I think that we'll really start triaging that. I mean, we're already seeing a greater demand for home healthcare, so that ICU unit at home. Heck, back in 2014, I was doing ICU unit stuff at home.
Yeah.
And we were sort of just dipping our toe in stuff at that moment. And whereas now, it's a whole different piece. Then we were doing it because there was a gentleman that, wanted to be at home. And he was like, look, whatever happens, I want to stay at home. We really pushed to help make his wishes come true. But today, I think there is an absolute need for it. But I think we need to be in more pain. We will be in more pain, and in 10 years' time, that whole system will just morph. And the way that it will be billed, I think, is the interesting piece.
Yes.
And that will define how effective the whole thing is, because the issue is in how things are paid for in the UK. That is kind of where our problems lie, effectively.
That's so interesting. So I think, in any case, you and I often share the same views here. but I absolutely agree with you. I think, there's going to be a shift definitely happening towards the community. First, because that's where we want healthcare to take place, but also because that's economically the most viable model. So, the way I think about it, you look at the pyramid, the top is like the most expensive surgeon, and the bottom, to be honest, are the care workers and minimum wage. And what the system is trying to do right now is to push down the services that do not require that level of skill to really lean on a cheaper workforce. And I say, care workers could do a lot of the nurses' work. Yeah. And conversely, a few really qualified nurses could do the job of a GP. Mm-hmm. And that could be cheaper at home and much better coordinated. So we will see that shift happening for economic reason and efficiency reason.
And I think actually the other really wonderful benefit from this will be, I think that will force us to pay care workers at a much higher rate.
Absolutely.
Which is great, rather than spending £800 a night on a hospital bed, let's spend £10 more on a care worker.
So you will basically fluidify, or you will break this kind of glass ceiling between the two. When we talk about social care, just the word social care drives me nuts. This is an arbitrary budget definition between healthcare and social care, because these are local authorities and NHS trusts. The truth is, it's a single healthcare system that should work together. And I think healthcare is keen to push down to the local community more of the services, and they will pay for it. So I agree with you. Now, on who pays for it, I am utterly convinced, and we, as you do, talk a lot with the government and policymakers. The intention is there for more prevention, more community care enabled by technology. The 10-year NHS plan is obvious. The funding mechanism or pathways are not there at all. There's a huge inertia in a public monopoly that's been around for 60 years. I doubt it's going to change from one day to another. So that's fact number one. Fact number two is healthcare is still one of these systems where we don't pay by outcome but by means. Yeah. If I build a house, which is wild. If I build a house, and my architect basically screws up entirely the plans, or the mason, destroys the house while building it, I'm not gonna pay them. Yeah. Here in healthcare, whether you have an incredibly qualified GP who basically really treats you the best way possible, or a very average GP who basically gives a wrong diagnostic, they're gonna be paid by the intervention. Yeah. We do not pay by outcome. And it's not about the people's quality, it's more about optimizing for outcomes. And that is a system that is really hard to put in place. We've tried in the UK, in the US, they have value-based healthcare, which is not working so well. It's working, but still has to pick up. I think that in terms of who pays, you will see a shift towards private. And I think private will action that outcome-based model, because I will have agency to care for my mom. Mm-hmm. And if you Walfinch should tell me, well, we'll look after your mom and we'll make sure that she's fine. And there's the nutrition looking at the dashboard. And over time, I'll say that's where the money.
Yeah.
And so this is how you activate this kind of outcome-based model. And then once you have scale and you can evidence it with real, health economics, saying to the government, the NHS, it saves you $5 billion per year, then they will embrace it.
And I think the interesting part of it to me is the pressure is so deep on the NHS that an older person trying to get a doctor's appointment and trying to have a long enough at an NHS appointment with said GP to really go through the information. I mean, frankly, that's almost impossible unless something's wrong. So the fact that as a care provider, I'm in a situation where I can get this, data and say, well, okay, here is Mrs. Jones's hydration, here is her medication intake, here is her mood and the changes in that, and all of the other things that kind of come in to that. I mean, that is really interesting. When you throw some wearables into the mix there as well,
absolutely.
And all of a sudden, I've got this kind of data over a 90-day period, which will really help me with AI and so on to really kind of start getting into, well, this is what's going on here, this is what to do. And then I'm using that 15-minute GP appointment to a really high level. And when we're talking about ROI, well, all of a sudden, I'm not sort of sitting in this appointment saying, well, I've got this cough and so on, but actually I'm talking, well, here is my heart rhythm for the last 90 days. Here is my average blood pressure. So,
it's so right. And I think, we should not underestimate how geriatrics is a complex topic.
Yeah.
It's like, if an older lady, as you know better than I do, but goes to a GP, if she goes in the afternoon or if she goes in the morning, the key health variables, so like the vital signs such as heart rate or temperature, may be widely different because of the medication they take. The GP will base their opinion on these measures at that moment. Mm-hmm. They may dictate an entire different regimen and actually treatment based on these variables. So how insane is that? That because she went in the morning or the afternoon, she may take path A or path B for the next 6 months in terms of treatment. That's insane. And so I think you're absolutely right. Home care is uniquely positioned not only to have that longitudinal data, this regular data every day, every hour. That's incredibly powerful in healthcare, but more importantly, a wider set. Because in healthcare today, it's all about vital signs. And what about food intake? What about social connections? What about cognitive? And that for chronic conditions and chronic conditions or chronic diseases is what we need to focus on. That is as important as these vital signs. So for me, home care, whatever the channel, care workers, or you're right, robotics, or maybe sensors, but is uniquely positioned to actually have more to have more data than anyone else. You will solve healthcare through that. Yeah. So
I truly believe that. And I don't know if you've ever heard of Dr. Lucy Pollock. She wrote the Golden Rules, and we had her on the podcast in Somerset actually.
Okay.
And she's very cool, and please tune into that episode. And she talks a lot about how we've got fundamental issues with how we prescribe medication to older people. She's a geriatrician, and there are very few actually in the UK.
There's very few,
And she's, she is phenomenal. Her writing is phenomenal, and when she does public speaking, you're sort of like, exactly that. It's the way that we commission medication, for example, for older people, and half the time it's all actually we're giving them a cocktail of medication that doesn't work together, shouldn't work together, but we're just piling it on. No one's then re-looking at that. And then they go for that appointment with those vitals because of that medication.
Exactly.
And it's just a downward spiral when actually nobody's just looking at the holistic
picture.
Because no one has the time for it,
exactly.
unless you're paying privately. So I recently had a health check done, and it was super interesting. It was privately done, and I spent, I don't know, a couple of hours and lots of very awkward samples and et cetera, et cetera. And we went into lots of information about, and I'm interested in that kind of longevity piece.
Of course.
Thinking, well, okay, so right, it's not just a health span. It's it's not just a lifespan. It's a health span.
It's a health span.
But it's then also saying, well, what would be better? I end up getting one of these, Whoop. Right. So I did get this a few days before going off to Vegas for the IFA. So my data's not so great right now, and apparently I need a bit more recovery.
Yes.
But it's.
I mean, I have a toddler, 16 months, telling me, I mean, like, it's the most depressing thing ever.
You need sleep. Well, no.
Yeah, I know. I'm aware of that.
Thank you for that information. But I think what I thought was interesting was having that benchmark data today. And so I've been doing that for a few years, but having the benchmark data to say, well, what is my testosterone level, in my 30s compared to my 70s and so on. Just sort of saying, well, okay, well, where does the intervention need to happen based on me and my personal bespoke information to then put into whatever system is available at the time.
Absolutely.
To say, well, yeah, I've been tracking my BP for the last 20 years and so on. It's a really intriguing piece that we're just not really talking about.
No, I fully agree. And I think you're absolutely right that continuity of data will be key. It's very disjointed today.
Yeah.
I mean, and so there's two things in what you said, which really, three things. One, geriatricians, there's very few, which is a proof that the model hasn't adapted itself. We still, a doctor, with all respect, has been trained probably, 30 years ago or 20 years ago to fix issues. And that means, either a real serious intervention at the hospital or a treatment which is based on medication. But rarely will a doctor go beyond, a few of the exercise, recommendations. But do we really have a holistic plan of care? No. I mean, it's about fixing the mechanics with medication, which, was working very well for one-off issues, episodic care needs, but doesn't work for chronic conditions. Nobody is really on top of chronic condition management. And geriatricians, there's not enough of them. Mm-hmm. You can keep people much healthier with other things than medication. And when you talk about medication, like on average, an older lady or an older man above 65 years old, 70 years old, sorry, who has 2 or more comorbidities, has an average of 7 or 8 medication that is being prescribed to them. Often, half of them are there to neutralize the secondary symptoms of the first half. And very often they're not compatible. Because nobody has done any clinical research about compatibility of disease, of medication. I mean, I know very well. I worked in pharma as a consultant for a little while. I know exactly. When they do their research, they do it like really with one chronic condition and no other medication at play. We don't know whether they're compatible. And so I agree with you that it's very old-fashioned in terms of how we look at it. And I agree with you that the data being longitudinal is absolutely key. And the last piece I want to say is the agency of the customer, the patient. I mean, the customer being, the care recipients in your view. But what you just said is interesting. You want to have a hold on that. And so you and I are probably early adopters, but I know that in 5-10 years, the younger generation will say, I want to be on top of my data. Do I trust the health system to, in a black box, tell me what's going on? I don't even have access to that data. And I have one person who has authority to dictate my future. And maybe that person is incredibly competent, maybe not. I want to have agency in the way I look after myself. And we need to give that agency to the patients. There are risks. Not everything is, you don't have all the answers on ChatGPT for sure, but there might be a way to give more agency to the patients to look after themselves by understanding what's going on better and not leaving it entirely to the authority of a GP. And, I still ask the NHS to have access to my last scan and they say, oh no, that has been sent to your local surgery. I was like, it's me. It's my scan. Why can't I see it?
It doesn't belong to you though.
Yeah, exactly. It doesn't belong to you. And so I think that agency will be really important. And by the way, in terms of prevention, as much as you can, there's a part of the system helping people to work more on prevention, but there's going to be also some responsibility in the hands of the patients themselves. You and I, we know that if we don't exercise, if we smoke, and if we drink a lot of alcohol, it's not going to end up well. We need to give that agency to the patients so that they can take the responsibility as well, understand the consequences. When you read the book Outlive that you and I read, you see your future. And you see the kind of path you can take.
And that's actually putting aside all of the more recent public information. But I think that is really interesting. It changed the way I started thinking. I probably picked that book up about 3 years ago, maybe just over. And it really shaped the way I was thinking about information about the way I was exercising and weight loss and
Yeah.
all of that, and thinking, well, okay, well, actually, why am I doing it? You know, because historically it was always aesthetic. But
Yeah.
actually, then there was a shift towards thinking, well, no, actually, when I'm 90, I want to be, you know, playing with my grandchildren and tying my shoelaces. And it's, you know, can I do those things? Am I strong enough for that? And, you know, I've changed the way I weightlift today for that reason. So I think that's an interesting,
fascinating way to position it.
Yeah.
The way that he's brought it, saying it's about what you want to do when you're 90,
Yeah.
and not just the aesthetics,
Yeah.
or the you need to exercise because it's good for you,
Yeah.
is brilliant.
Yeah.
Because now you're in charge of your future.
Yeah.
You take it, you don't take it. But
Yeah.
I want to be able to carry my grandchildren.
Yes.
If I want to do that, I got to
Yeah.
get started now. And so, yeah.
It's a simple enough thing, isn't it? And it's actually it hits home.
Exactly.
You know, so
It hits home. Yeah,
so
absolutely.
I've got two last questions for you, Max.
Please.
My penultimate question is, if you had a magic wand, what would you change in the health system if there was one thing that you could change?
I think I would change the incentive model. What I mean by that is, as I said, I think you see adverse incentives. In any market, I'm an economist by background. In any market, the less frictions there are for the market to adjust by itself, the better. You need to regulate, to put safeguards. But a market can self-regulate quite well, and then they will find the optimum. What I mean here in healthcare, it's a public service, and it should stay to some extent because it's incredible, you know, in terms of solidarity and, you know, free access of care at the point of care. I really, you know, these are my values, I endorse them. But it creates a lot of friction in terms of incentives. And that means that we're slowing down innovation and we're not optimizing for health outcomes. So concretely, what does it mean? It means that we need to find a way for the patients and the care providers and the payers to be looking towards the same direction and for the same outcome.
Yeah.
And for the moment, that's not the case. And it could be co-payment model. You know, maybe people should start paying a little bit for the kind of service they get. It could be that you give more agency to the patients to choose for the service they want, so that, you know, they can optimize for their own health. There's different paths. Different countries have tried different things, but I think it starts from how you incentivize financially, because otherwise we're never going to solve some of these. The technology is getting there. The people are committed. You know, so we have all the ingredients. But like the funding flows, the economics don't work for the moment.
Yeah. I've got to agree with that. I think, you know, it's. I was thinking, what would I, if I was asked the same question?
While you ask the question.
Yeah, you know, I was thinking, well, what do I think to that? But actually, it's really about where the money goes.
Yeah.
And fundamentally, that would change the whole thing.
Yes.
It would change the entire game.
Yes.
So that's great. Thank you for sharing that. And the last question I've got for you that I often ask people at the end of the podcast is, if you know, we've got a lot of entrepreneurs and, you know, carepreneurs that tune in, and if you were advising our audience with one actionable item on how to move in business to make your first million or your next million, what would that one actionable item be?
As a care provider.
I mean, you can go broad. You can go broad as a business owner. I'm just saying, for context, we have a lot of carepreneurs in here, but
one action. This is very entrepreneurial. I would start with the customer. So one action is just become a care worker.
Yeah.
And just, you know, go and care.
Yeah.
And that's the best way to think about the solutions you can put in place, or the future models of care and so on. Like, get as close as possible to the problem that you're trying to solve, which is the patient, the older adults. Become a carer.
I love that. Thank you. What a wonderful place to stop. Thank you very much.
Thank you, Henry, for the invite.
It's a huge pleasure.
Yeah, as always. Thank you so much.
And thank you for tuning in. Until next time.